hypo or hyperthyroid. It's hypo or hyper pituitary. It's hypo or hyper adrenal. Sounds easy. We're going to talk about it.
Is it parathyroid?
We're not really doing parathyroid. Remind me to mention it in the context of thyroid.
Okay.
Parathyroid glands are attached to the back of the thyroid glands.
Mm-hmm.
And basically what they do is control blood calcium level. Really parathormone from the parathyroid. But we're really going to talk in depth about the thyroid gland. So hopefully, good morning, everybody.
Good morning.
Yes, so this is a class day. I want you to relax and think endocrine, because we're going to do endocrine this morning. I do have your test that you can see at the end of class, but let's go ahead and get started, because I want to finish diabetes mellitus, understanding that you have had some material on it in the lab. Okay, that's okay. You haven't had labs. Tomorrow is your super lab. Tomorrow is super lab. You're going to have like 20 minutes of TPN. Ken and I talked that. Then we're going to do diabetes, and after that we're going to do diagnostic procedures. The LD5 people are just going to do diagnostic procedures today, because for some reason, Wednesday has been a sweet spot for this winter. For some reason, we haven't lost anything on Wednesday.
Thank goodness.
So you haven't lost any of your Wednesday classes, and you haven't, people that have lab on Wednesday have had their labs. We lost clinical time, and some people have lost a lot of lab time. So you'll get your lab tomorrow.
Are they going to extend the semester?
No, not that I understand. At this point, I haven't heard that.
That's not.
They want us to keep everything on schedule as much as possible, now that all courses on campus require the faculty to use Blackboard to post information and assignments and communicate with students. So we're hoping that we won't have to change the calendar. I don't intend to for 2020 or 2032.
Okay.
Okay? So unfortunately, we don't really need to for the Wednesday classes. Yay!
But if they just, but I was just wondering for the whole, because I know
For the
2020.
I don't know. I
Okay.
don't know. I haven't heard anything official from the college. Okay, so let's start talking about diabetes mellitus. Hopefully you have your study guides open to your information. Competency 7, which we started last week, page 73, 74, 75. Then you have your content outline. On page 85 and 86, there are a few case studies. So we might try to do that a little bit before we go into competency number 8. And then competency number 8 is everything else you want to know about care of nursing care patients with endocrine disorders. And we'll focus on the pituitary gland, the thyroid gland, and the adrenal glands. Okay? All right. And yes, this week's lab, we're going to talk about some diagnostic tests, but that's not on the next 2020 exam. That really goes more when we start the oncology information. But we do need the diabetes lab to go with this competency. And in the diabetes lab, you'll cover insulins again and talk about mixing insulins and insulin pens. Okay? All right. So last week, after the test, we talked about the definition of diabetes mellitus, which of course is an endocrine disorder of what gland?
The pancreas.
The islets of Langerhans of the endocrine pancreas. And so it's abnormal management of what? Blood glucose, right? 10% of people with diabetes have type 1. And of course, then they are insulin dependent. They have destroyed beta cells and they don't make insulin. So if you don't make insulin, you can't use any other form of medication than insulin. Okay, and we'll talk about the insulins again in lab in a few minutes, about 10%. The increasing incidence in this country is people with type 2 diabetes, which does increase risk with age, but unfortunately now we have younger people developing it. So what are some risk factors? What are some non-modifiable risk factors? When you talk about primary prevention, you talk about what people should do so they don't get sick. And so in this case, people always want to know, for any disease, but in this case it's important to know people's risk profiles. What are the non-modifiable risk factors for developing diabetes? Your age, increase with age, race, ethnicity, family history, kind of all related. Gender, okay, not so much gender in this disease. Okay, so there's a lot of other things, history of gestational diabetes, so your medical history, your family history, that sort of thing. What about modifiable risk factors?
Diet, exercise.
Diet, exercise.
Lifestyle.
Maintaining a normal weight.
Lifestyle.
Lifestyle. All that stuff comes under lifestyle, doesn't it? Those are modifiable risk factors. Things you can change to decrease your risk. Okay, and so in type 2 diabetes, pardon me? Smoking is a risk for a lot of things, including vascular problems and diabetes. Absolutely. And we'll talk about lung cancer and some of those things in a few more weeks, and that would be too. And alcohol. Alcohol messes up everything. Too much ethyl alcohol can also affect your liver, which helps to control your blood glucose along with your pancreas.
And hypertension.
And hypertension can affect it. Diabetes is more likely to cause hypertension than the other way around. But if you have diabetes and hypertension, or just hypertension alone, that puts you at risk for chronic kidney disease, right? Along again with family history and genetics. Okay. So type 2 diabetics may have a decreased insulin secretion, but a lot of it is insulin resistance or decreased sensitivity. They're making insulin, but they're not responding to it anymore. And so they may require insulin, or possibly they can get away with just an oral agent, which we'll talk about in a second here again. And there are some people, we had a dean here who was diagnosed with type 2 diabetes, and she went on a really strict diet and exercise program. She lost a lot of weight, she exercised religiously, she ate really well. She actually was managing her blood sugars, as evidenced by her hemoglobin A1Cs being normal, her glycosylated hemoglobin, which is the test of 3 months of glucose control. She was doing it with diet and exercise alone. Now eventually, she couldn't keep that up. So she's on the pills now, and she has put some weight back on. But she's still managing her blood sugar. She just isn't doing it without the meds anymore. She couldn't keep up that. It was a really strict diet and exercise plan. That's all I'm going to say. It's hard for people to make huge lifestyle changes. We want people to make some lifestyle changes, but we want them to be something that they can continue to do over a long period of time. She's still managing her disease, but she's on meds now too. All right. We know that diabetes mellitus affects the vascular system, the blood flow through the body. The plumbing that perfuses the heart and the feet and the brain and the kidneys, all of those things. The large vessels, we can say people are at risk for coronary artery disease. The vessels that perfuse the myocardium, if somebody occludes their coronary artery and tissue dies, we call that a myocardial infarction. PVD, peripheral vascular disease, of course, the risk of amputation of feet in particular, but also legs, even sometimes other parts of the body, is higher incidence. And then stroke, which is cerebrovascular disease, a thrombotic stroke or a narrowing in the vessel of the brain can cause a brain attack, which is a stroke. Smaller vessels, same concept. Doesn't really matter whether it's macro or micro, but the vascular system's impaired. And so the vessels to the eye can cause a lot of ocular complications, including blindness. Neuropathy to the peripheral nerves, sometimes the autonomic nervous system, such as autonomic gastroparesis, with problems emptying the stomach. We think about the numb feet and the importance of foot care. Diabetic nephropathy and chronic kidney disease and male erectile dysfunction. An issue of blood flow. Okay, like they say in the commercial. We talked about DKA, type 1 diabetes, high blood glucose, above 300 milligrams per deciliter. It's a metabolic acidosis, so the blood pH would be low. They become very dehydrated. Remember, what are the 3 P's of diabetes mellitus?
Polyuria.
Polyuria, which if you pee out too much, you can get dehydrated. Polyphagia, polydipsia. Right. When we talk about diabetes insipidus, people with diabetes insipidus still get polyuria, but it's because they have decreased anti-diuretic hormone. It's got nothing to do with blood sugar. So they're 2 completely different diseases. But in both cases, people pee out large volumes of urine and they can get dehydrated. Okay, so if you're dehydrated, your serum sodium would be elevated, as would BUN and creatinine. And because they have metabolic acidosis, they're going to spill out ketones in the urine. Yes? A greater than one should be a greater than sign.
Yeah, But I don't understand it because even
If somebody's-
36 is still normal range. but
Yeah, I
130
know.
to
It's not really
145.
usually not a big player, so I wouldn't worry about the sodium.
Okay.
Just think about metabolic acidosis. That works better for you. And the signs and symptoms. The signs and symptoms are mostly around the dehydration. So, and the metabolic acidosis, but you know the signs and symptoms of dehydration, which if it gets really dry, they can become hypovolemic and hypotensive. If they're hypotensive from hypovolemia, they're going to have compensatory tachycardia. With hypovolemic shock, people get higher heart rates to try to maintain cardiac output. And then Kussmaul's respirations. Kussmaul's respirations is an abnormal pattern. What is it? What does it look like? Deep and rapid, deep and fast. Good. Tachypnea and a deep, rapid respiratory pattern. And that is to try to blow off the hydrogen ions. It's respiratory compensation for the metabolic acidosis. And then, of course, decreased level of consciousness, altered mental status. They can become confused, lethargic, and even unconscious in DKA. Okay, so you want to, it's a critical care situation. You want to monitor them closely. They'll be either, admitted through the ED to the ICU or moved to the ICU. They're going to do close monitoring of vital signs of urine output, of level of consciousness. They're going to look at hydration, fluid and electrolyte balance. So what's a couple ways you can look at fluid and electrolyte balance if you're the nurse taking care of this patient? You can look at weight.
Their skin tone.
Intake and output, absolutely. And you can also evaluate the patient's labs, right? Look at their electrolytes. See if they're hemoconcentrated, they might be falsely elevated. We see a lot of elevated BUNs in patients with dehydration, don't we? Then we give them a couple liters of fluid, their BUN's okay. That's just because they're dehydrated, not because they're in kidney failure. Now, people with diabetes could also be developing kidney failure. So you might see that in their labs in addition to the DKA. Okay, so look at labs too. So what's the treatment for DKA?
Insulin.
Insulin and fluids. For the hyperglycemic emergencies, key there is hyperglycemic, you're going to treat hyperglycemia with insulin. So they'll do an insulin drip, usually mixed saline with regular insulin. And they may also have another bag of saline that they're managing the dehydration with fluid. So as their blood sugars drop, what else does insulin do besides drop your blood sugar?
Drops your potassium.
Drops your potassium. That's the next bullet. So we give insulin for severe hyperkalemia as an emergency treatment. In this case, we're not giving it for that. We're giving it for hyperglycemia. But you still have to monitor their potassium levels and make sure they're putting out enough urine before you give potassium because you don't want to get it too high. Replace fluid and monitor for fluid overload because you're giving a lot of fluid. And then you want to prevent it in the future. And I've had peds people tell me, yeah, a lot of these diabetic kids, when they become teenagers and they want to be like their friends, it may take 1 or 2 admissions to the PICU at Children's Hospital with DKA before they recognize that they can't do everything the same as their friends. That they have to modify their life so that they're taking their insulin correctly, so that they're managing their blood sugars. A lot of these kids now, if they have the right insurance, etc., are using insulin pumps. And insulin pumps are wonderful because they give a basal rate, they dial in the computer, they have the little catheter in their sub-Q tissue in their abdomen, and they can punch in the amount of insulin they want to give themselves based on their blood sugars. They'll check their blood sugars frequently, and then they'll program their insulin pump based on their blood sugars. Okay? If someone has eaten, they'll put in more insulin, etc. If they're exercising, they'll dial it down.
Can they go swimming with that?
Mhm.
Okay.
There are ones where you can put the little cover over it and they can actually do things like shower and swim. Yeah. Okay. And this is when to call the doctor. So that's part of your nursing teaching anyway. When does this patient have to worry? When should they contact their health provider, their endocrinologist, their primary doctor, their diabetes nurse educator, whoever it is that's managing their diabetes? Which means they have to have somebody that is managing their diabetes and doing it well.
I know that we dipstick in the hospital for ketones.
Ketones.
Is that
Not
something
you.
that someone at home would do?
Oh, yeah.
They would keep
Sure.
things to dip their own?
They can have the little
Okay.
dipsticks, and they can dip their own urine.
But would that be standard for someone who has like type 1 diabetes
Yes.
to keep dipstick things around?
Yes.
Okay.
Yes, along with their glucometers, their insulins, all of that, they would also have the dipsticks in case they are getting hyperglycemic and they want to see if they're getting ketotic and ketonuria is happening. Right. Mm-hmm. Yep. All right. HHNC is hyperglycemic hyperosmolar non-ketotic coma, which is the hyperglycemic emergency in what type of diabetics? Type 2. So they can get really high. They can walk around. They can tolerate a fairly high blood glucose before they really get sick. They might be 3, 4, 5, even 600 and be pretty okay. But above 800 milligrams per deciliter, they're going to get into this really bad dehydration situation. Severe dehydration and electrolyte loss, decreased renal blood flow. Their blood gets real thick, which is a high osmolality. Often precipitated by some other kind of illness or some kind of medication that increases their blood sugars, like steroids. The older the person is, the more they're at risk because they don't have, a strong compensatory mechanism. So for HHNC, same treatment. We're going to give them insulin bolus, insulin drip to bring down the blood glucose, along with a lot of IV fluid. So what IV fluid would they start with? Normal saline. Obviously nothing with glucose in it, or dextrose, because dextrose is the same thing. Okay. And then because they're sensitive to overload, you want to watch their central nervous system function and, of course, their other vital signs. Anybody with diabetes, especially these days with tight glucose control, people are checking their glucoses 4 times a day, giving small amounts of insulin to cover that, trying to maintain that normal 60 to 110. They're at risk for hypoglycemia. You want to get that door, somebody in bed? You don't have to actually lock it in case somebody's still coming in. Okay, so we have these symptoms that are related to the drop in blood sugar. If you've ever been a little hypoglycemic, probably everybody has at some point. Some of you may even be more sensitive than others. You'll start to feel hungry, maybe even get a little weak, sweaty, nervous, irritable, shaky. That's hypoglycemia. And then as it continues to go down, you can have some altered mental status, starting with a headache, but confusion, slurred speech, changes in behavior, talked about being nasty or cranky, irritable, and then even lose consciousness. All right, so we know for mild, moderate, and severe hypoglycemia, what are we treating them with? Sugar. Okay, so for mild hypoglycemia, and they're still doing pretty well, maybe a little shaky or hungry or irritated, they can do 4 ounces of orange juice or other juice, sugary juice, 4 ounces of soft drinks, obviously sugar soft drinks, not diet. They have glucose tablets they can buy. They can eat saltines or graham crackers or hard candies, or get out the sugar bowl and eat a couple teaspoons of sugar. And then what do we need to know after we treat hypoglycemia? 30 minutes after we give this, we have to reassess. We have to see if it's come up, how much, is it still too low, is it now too high? You need to know what happened. So it's not just about the intervention. You have to evaluate the efficacy of the intervention. So that's the whole process. You can't just assess, you have to assess and intervene. You can't just assess and intervene, you have to assess, intervene, and evaluate. Okay. So now as they're getting more hypoglycemic, they're going to get more decreased level of consciousness, and they want to give now more sugar, 15 to 30 grams of rapidly absorbed carbohydrate. And then it's also good to give a protein or a complex carbohydrate that's going to last longer so they don't bottom out again. And for somebody who's unconscious and they can't swallow safely, now we have to give them, ideally an IV, because IV is the fastest way to give meds. And what do you push into the vein? D50, dextrose 50%, which is available in pretty much all crash carts and emergency kits in hospitals and also long-term care facilities. Okay? And glucagon if you can't get the IV for D50. All right, so then you want to teach people not to have it happen again, don't you? So what drops your blood pressure? Exercise, insulin or other meds. Alcohol can cause a spike and then a drop, or not eating. So obviously you as nurses know that if the patient's MPO, you don't give them their insulin. You check their blood sugar. You might need to give them insulin if the doctor says to, if their blood sugar is high. But mostly the concept is no food, no meds. And the patients need to know that too. No food, no meds. If they're NPO for a test or surgery, they should hold their insulin. People get into trouble doing that. We want to make sure they're connecting the same dots because it's their disease and we're responsible for them understanding our teaching. Yes.
What if it's sliding scale insulin, but they're not eating, but they're still elevated?
In that case, you need somebody else's opinion, like a doctor. They may say go ahead and give them their 2 units of Humalog anyway because they're 300,
Okay.
and we want to manage the blood sugar. Okay. But if they're NPO, you would probably need to get orders to give it. Sometimes we're giving the sliding scale anyway because it's such a small amount, and we're trying to maintain normal blood glucose. But if they're taking something once a day, like Glucotrol and Glucophage, and they're NPO that morning, then they would need to probably hold it. Because the pills can drop your blood sugar too much too, can't they? All right, this is just information you want to have about the patient. All right, so now we're going to talk briefly about the meds. In your study guide, there's a couple of pictures. I think it's in the back, where you have, okay, page 241. I like this chart because it shows you class 1, class 2, and class 3 oral hypoglycemic agents. Page 241 on the back of your study guide. Or if you've moved it with competency 7, it'll be right over after the page on insulin. So this is nice because they're right together. You do the oral meds first and then they do the insulin quickly. Okay. So type 2 diabetics may need oral agents if they can't achieve blood glucose control with diet and exercise. The first category here on the list says sulfonylureas. This is your first generation was the old diabeta micronase. Now we have glipizide, which is glucotrol. We have Amaryl, which is glimepiride. And what do they do? Look above it. Class 1 meds stimulate the beta cells to release more insulin. Okay, so a lot of these patients will have an oral sulfonylurea, like Glucotrol or Amaryl. So what are the side effects? Well, hypoglycemia is the major side effect, right? Just like what's the major side effect of oral of any root, of anti-hypertensives? Hypotension. So what's the most common side effect of oral hypoglycemics? Hypoglycemia. Right. Okay. Well, that's the concept, isn't it? And it can be serious. It's the most common and most serious complication. Other side effects could be some blood dyscrasias, so people should have their CBCs checked. You know, their red counts, white counts, platelet counts. Skin reactions, they can have allergies, rashes, etc. And then good old GI side effects. That's a pretty safe side effect for almost any medication, isn't it? But it can cause some nausea, etc. So this is a side effect profile for the class 1 drugs. The other class 1 drugs here are the meglitinides, which you don't see used very often. Meglitinide analogs, pretty much the same as sulfonylureas, similar in chemical, similar side effects. First one there says hypoglycemia. They could get some joint pains or back pain or headache. These meds, the sulfonylureas and the meglitinides, should be taken 30 minutes before meals. So that's the concept of oral meds, isn't it?
Yes.
You want to take oral meds 30 minutes before meals. It's not going to work in 2 minutes like an IV push. It's got to be absorbed by the gut and get into the bloodstream. So 30 minutes before meals is the best time to take these meds. Now there's another category called class 2 agents, and the only one available in this category, the biguanides, in this country is called metformin. Metformin, or the brand name is Glucophage. So if your patient is getting a sulfonylurea like Glucotrol, they may also be getting a biguanide like Glucophage or metformin. And then there's another newer category called the thiazolidinediones, which are actually going out of favor. You see the 1-800-BAD-DRUG? You know, if you took Avandia and you died, call this number, we'll get you money. It's literally what someone will say. If you listen to those things, it's crazy. Okay, so Avandia and Actos, also act to do what? How do the class 2 meds work?
Synthesize the body.
They increase insulin sensitivity, which is another way of saying decrease insulin resistance. They don't increase insulin secretion, but they decrease insulin resistance. So they found out that the Actos and Avandia type meds cause a lot more heart failure and liver failure than they originally thought. So it says here, enhance insulin action, says liver function studies should be done. Yeah, that's because it can be liver toxic. Side effects are fluid retention and weight gain. Well, that's because they're getting heart failure. So now they're not as hot on Avandia and Actos. The drug companies were making a lot of money selling those. They were very expensive. And now they're pretty much gone except for special cases. It's what they call a black box warning. It means that the FDA has found out they're dangerous and they're trying to make sure the docs know that if they're going to prescribe it, that they need to think twice. So they're still giving metformin, glucophage, but not so much the Avandia anymore. Okay. And then the class 3 agent there is called a alpha-glucosidase inhibitor. So they inhibit an enzyme that absorbs carbohydrate from the stomach, from the gut, from the GI tract. So where do these work? They work in the lining of the stomach. They reduce postprandial, meaning after you eat, hyperglycemia by slowing digestion and absorption of carbohydrate in the GI system. So it just keeps you from absorbing some of the carbohydrate you eat. So when would you take it? You want to take it with the food. Take with the first bite of the main meal. And that's because you want it to go down with the food and act in the GI tract to prevent carbohydrate absorption. So guess what the side effects are? If it works in the GI tract, what kind of side effects will you have? GI side effects. So GI side effects are the things like gas, abdominal pain, diarrhea, that kind of stuff. Probably be smarter just to not eat the carbohydrate in the first place, but you know how people are. They want a magic pill. And speaking of magic pills, there's actually a couple of new categories of drugs that they're trying to sell. Again, a lot of people have type 2 diabetes. They don't want to change their lifestyle. They just want to take a pill. And so you'll see another new category they're talking about. Farxiga, Farxiga. There's a lot of commercials out there now. And it's going to actually act in the urinary system to help flush sugar out. So that's Farxiga. The flea zones, or the, flitigones, something like that, is the end of the suffix of the generic name. So that's some newer ones that they're trying to sell. We'll see if they end up in the same situation as Avandia, where they were found out not to be that helpful, or even worse, to be more toxic than they are saying. But these are big money makers for the big pharmaceutical companies. So they're starting to try to have some other new pills, and Farxiga is the first of that category that acts on the urine. Okay? All right, but these are the ones you need to be responsible for: class 1, class 2, and class 3 oral agents. So what would be your most common side effect of people taking these pills?
Hypoglycemia.
Hypoglycemia. There you go. All right, and you can combine them. Glucovance combines glyburide and metformin. All right, insulin. We know type 1 diabetics must have insulin to live. Moderate to severe type 2 diabetics, if they're not managing their A1Cs, they may need to add insulin to their regimen. Look at the insulin sheet here you have on page 240. Down the left column, it gives you the brand and generic name. And then it says whether it's clear or cloudy. Then it says when to take, starts working, works the hardest, stops working. So that's the concept of onset, peak, and duration, right? All right, so we used to use regular pretty much for everything. Regular is now sort of secondary to the, regular is a short-acting insulin. Let's look at regular first. We know it's clear. How long, what's the onset for the action of regular? 30 to 60 minutes. Doesn't start working for 30 minutes. So we used to tell patients when they only had regular, take your insulin and think about your breakfast. Make your breakfast 30 minutes after start to eat. But now we have Lispro and Aspart. And how long do they take to start working? 5 minutes. The peak is sooner. So we mostly now use Humalog and Novolog, don't we? For the sliding scale, you'll see in the hospitals, mostly pens, the insulin pens, and it's mostly Humalog or Novolog. And that's what we use for sliding scale insulin coverage. AC and HS, we do blood glucose. What's AC and HS?
Before meals, no.
AC stands for before meals, anti. HS is hour of sleep, so 4 times a day we do the blood glucose and we cover them with Humalog or Novolog based on that glucose, or not if it's low enough that they don't need it. Okay. Regular still used for insulin drips. It's still around sometimes in EDs, ICUs, etc. But mostly now we're seeing Humalog or Novolog, the rapid acting, instead of regular, the short acting. We still have NPH, which is an intermediate acting insulin. It's cloudy. The onset is 2 to 4 hours. The peak is 4 to 10 hours. The duration can be as long as 16 hours. But usually it's gone in 10 to 12 hours or so. All right, and it's cloudy because there's a preservative added to it to make it absorb more slowly. Now, those of you that had that lab, LD5, we already talked about all this. LD1, you're going to talk about it all again tomorrow. And now we really only have one chemical type of long-acting insulin. There's 2 brands. One is Levemir that Doctors Hospital has, but the main one is Lantus. Lantus or glargine insulin. The nice thing about it is, what is the peak? The answer is there isn't one. Trick question. Well, that's a good thing. That means you can give it 10 o'clock at night, once a day, mostly at night, but some docs now give it in the morning, so can't ask that test question anymore. Usually at night, once a day, 24 hours, basal release of insulin, no peak. So it's nice. It prevents some of the problems we used to have in the middle of the night, like Somogy effect. And then there are combinations. Lantus cannot be mixed with any other insulin, but you could mix the short-acting or rapid-acting with the NPH. Okay? All right. So that's what all these words on this slide say. People need to know what they're on, how to give it, where to give it, what length needle they should use, depending on if they're obese or skinny. And then insulin, the best regimens are closest to the normal release, which is why things like insulin pumps have become very popular. And also they've advanced a lot with the computer technology, so that they can dial in or program in insulin to be released more physiologically to the body. Or people are doing 4 times a day blood sugars and covering with short-acting, with the rapid-acting insulin. Instead of taking 1 or 2 shots a day, they may take 4. Okay? All right.
So, Ms. Han.
Yes?
Yeah, so you said it doesn't matter when you take it anymore? So like saying generally at
Oh, you mean the
bedtime?
Lantus?
Yes, please.
I'm only talking about the Lantus.
Yes.
It's given once a day, usually at night.
Okay. So it's still going to be.
Just keep that thought.
Okay.
I have seen some endocrinologists that give the Lantus once a day at 10 a.m.
Okay.
instead of 10 p.m. But the point is, it's a 24-hour release, and it's given once a day, usually at night. Don't freak if you see it once a day in the morning,
okay.
because I've seen that too. Okay. Complications of insulin, same as the pills. Works even faster than the pills. So what's the most common complication or side effect? Hypoglycemia. And then you could have local problems in the areas where the injection is being given. Lipodystrophy, lipoatrophy, lipohypertrophy. So you know what those medical words mean. Atrophy means the fat actually atrophies or goes away. They have less of it. Lipohypertrophy means they have swelling or more of it. So what's the treatment or the prevention for these site problems? Rotating sites. So where do you give sub-Q injections? In the abdomen,
In the back of the arm.
in the back of the arm,
In the thigh.
in the thigh. If you have back fat, only if they do, you can put a little bit right there. Okay, sub-Q injection sites and rotate. All right, so here's 2 complications. I talked about insulin, and I talked about monitoring blood sugars and that sort of thing. So, Patient, let's see. Okay, so the dawn phenomenon and the Somogyi effect. So you've read about this in your chapter in Iggy, but let's just review it. Time. This is, okay, here's time. 10 p.m. 10 p.m. Okay. Three, 4, 8. Same thing. 3, 4, 8. I'm telling you right now, 8 a.m. seems like 4 a.m., doesn't it? Okay. So here's your blood sugar on the vertical axis. So you have, say you have a normal blood sugar at 10 p.m. Say it's 110. All right. So in the dawn phenomenon, well, in both of them, they're going to have morning hyperglycemia. They're going to wake up with fasting hyperglycemia. People aren't supposed to have fasting hyperglycemia unless they have diabetes. Most of us have fairly low blood sugar if we've been fasting. Okay, let's say this is 200. So far they look the same, don't they? So the patient starts out at 110 at 10 p.m. and ends up at 200 at 8 a.m. Same thing. Patient starts at 110, ends up at 200. All right, so the dawn phenomenon says what? It says that there is fasting hyperglycemia from nocturnal release of growth hormone that causes the blood glucose elevations around 5 or 6 a.m. So when does your normal cortisol get released? Usually in the middle of the night. That's why night shift people have screwed up endocrine systems. Okay, because they're not sleeping when they're supposed to be. Okay, so their blood sugar goes along okay, and then they start releasing growth hormone, and they wake up and it's high. Okay. We'll say 5 days. What the heck? That's called the dawn phenomenon. It stays normal. Cortisol and growth hormone are released. Cortisol and growth hormone increase your blood sugar, and you end up high in the morning. Somogyi effect is a morning hyperglycemia resulting from counter-regulatory response to a nighttime hypoglycemia. These are the patients that wake up in the middle of the night with nightmares, and they're hypoglycemic. So with this patient, they start out normal, and they start to go down. They drop. 3 o'clock in the morning, they're hypoglycemic. Their cortisol kicks in, and they end up too high at 8 a.m. Okay? So that's the difference between the dawn phenomenon and the Somogyi effect. So here's my NCLEX test question for you. Think about this for a second. Your patient starts out normal when you check their HS blood sugars, and your patient is hyperglycemic when you check their morning before breakfast blood sugars. How do you know the difference between dawn and Somogyi? Which are they having? How would you know that? You could. There's an easy one. There's one easy way to differentiate.
Well, Somogyi is a drop. 3 a.m.
Wake them up at 3 in the morning and check their blood sugar. If it's low, it's Somogyi. If it's normal or even starting to go up, it's dawn. Because they're bottoming out down here. They're pretty low. So they're hypoglycemic in the middle of the night. So it's not as bad as it used to be because now we have Lantus. When we had Lenti and Ultralenti and these long-acting insulins that would peak in the middle of the night, those were the patients we had to give a snack at night. We had to give them food before bed to help prevent the Somogyi effect and the nocturnal hypoglycemia at 3 o'clock in the morning. So they start out normal, they end up high, but at 3 a.m., these people are normal and these people are low. So if you wake them up at 3 a.m. and they're hypoglycemic and they're sweaty and shaky and they're having nightmares, obviously you have to give them some sugar, but that's called the Somogyi. You see the difference? Okay. Insulin's usually sub-Q. We're getting some new insulin devices that can push it through the skin. There's also some nasal insulin on the market now. The nasal insulin hasn't completely replaced the sub-Q insulin, but it's coming, it's getting there. It's going to be great for kids with type 1 diabetes who don't want to give themselves shots. It's going to be good for everybody if they can find other routes to give insulin. They can't give it oral, but they've got a nasal spray. They've done some research on nebulizers. They're working on transdermal. And I know we also know we can give it IV drip, but that would be for an emergency. So it's still sub-Q, whether it's a pen or they're drawing it out of a vial. So you want to teach the patient how to store it, prepare it, inject it, complications. They should use the same type of syringes, the same needle length. Obese clients shouldn't be using those little short needles that come with the standard insulin syringes, but a lot of people do. It just takes longer to absorb. All right, they need to know how to do their blood glucose monitoring. There's so many different kinds of glucometers, different prices. Some are very fancy. The thing that's expensive for the patient is the strips, and that becomes very expensive. Chronic disease is very expensive. Diabetes is very expensive if you're monitoring your blood glucose the way you're supposed to. The amount of blood on the strip can make a difference. Altitude, temperature, moisture, they need to keep them in a dry place. Even people's hematocrit or triglycerides, really high triglycerides, could falsely elevate. But they need to use them, and they need to do them properly. I've seen patients who tried to cut the strip in half so they could get twice as much, use. That doesn't necessarily give them an accurate reading. And then they have to clean it. They want to prevent infection, and they need to know what their insurance covers or how they're going to pay for it. Okay, that's insulin. Diet. Now, I'm not going to ask you on a test. You did have a lot of diet questions on tests too, didn't you? Yeah. You have to know what meds are dry. You have to know what meds have potassium, sodium, protein. You had to know that kind of stuff for the test. For the diabetes, we're not making you nutritionists or dietitians, but clinical dietitians need to be brought into the team for someone with newly diagnosed or poorly controlled diabetes. Because you want everybody on the team to formulate an individualized meal plan. And of course, the important thing is day-to-day consistency in the timing and amount of food eaten. And if they take insulin, they need to eat at consistent times, coordinated with the peak of that insulin. Okay. And then they need to look at lipid levels, blood glucose, and of course the A1C, which is the glycosylated hemoglobin. Protein should be 15 to 20% of calories if they have normal kidney function. If they have some renal insufficiency, then they're probably going to decrease their protein in that diet. Less than 10% should be from saturated fat, which I guess we all should be. This is the prudent diet for everybody, guys. You shouldn't have trans fatty acids. Those are artificial chemicals. Hopefully, we're starting to take those out of foods. Remaining calories are from monounsaturated fat and some carbohydrates. And it's important that they eat fiber because that slows the carbohydrate metabolism, helps with cholesterol, helps with normal bowel movements, etc. Artificial sweeteners, the jury's really out on that because some of these are pretty toxic chemicals in their own right. You know, aspartame is a neurotoxin. People that are addicted to diet sodas have been frying their brains with aspartame. It's really bad for you. And it's used in, it's NutraSweet. It's in a lot of the diet sodas. So do not drink diet sodas. Do not give your kids diet sodas. Don't give your kids any sodas if you can avoid it. The stuff is bad for you, whether it's sugar or not. I know, I like Coca-Cola, but I know it's bad for me. There's no nutritional benefit to any kind of soda. So those of you who are in cultures who don't drink it, good for you. It's a waste of money, it's bad for you. Fat replacers. The problem with low-fat diets, that was real big for a while. All the boxes in the grocery store said low-fat. Guess what they were high in? Carbohydrate. Otherwise, they were higher in sugar. They lowered the fat, but they increased the sugar. Otherwise, it tastes like cardboard. If you ever had bad low-fat food, it's awful. It tastes like cardboard. Yeah. So they put in more sugar. That's not good either. Alcohol in moderation, only if the diabetes is well controlled. Alcohol can really wreak havoc on blood glucose. You can kick it up real high and then drop it, bottom it out. And people need to read food labels. So you've all talked about therapeutic diets before. This is the therapeutic diet for diabetes mellitus. There is something called an exchange system. We're not going to ask you to get into the specifics of the exchange system. If you read your chapter in IGGI, it's got a lot of nice charts. The reason this birthday cake is glowing is because people need to be able to participate in life. Otherwise, they can't comply well, but they need to make adjustments. It doesn't mean they can eat birthday cake every day, but it means they can eat birthday cake if it's their grandchild's birthday and they want to eat a piece of cake. They work that in with the carbohydrate exchanges, okay? So that they can participate in social occasions. The problem is the American fast food diet is really bad. So those of you who came from places that cook from scratch, good for you. That's what's best anyway. I heard the Surgeon General, somebody said, how do we decrease the obesity epidemic in this country? And he said, learn to cook. He said, don't drive through the McDonald's drive-through and your kids eat the Happy Meal in the back seat on your way home from work. He said, that's what's killing us all. He said, it's the crap at the fast food restaurants. He said, learn to cook. Buy fresh fruits and vegetables, cook from scratch. You won't have the trans fats added. You won't have the chemicals for preservatives. Makes a huge difference. But long-time eating habits, cultural eating habits, this stuff is really hard to change. There are socioeconomic factors. They talk about food deserts in low-income areas where people don't have access to the same choices of fruits and vegetables and such. And some of that is more expensive. People who live alone have physical limitations, problems with vision, may have harder time following this prudent ADA, American Diabetes Association diet. And their website's really good. It's just www.diabetes.com. Okay, it's just diabetes.com. Pretty easy. And just like some of those kidney websites, they have a lot of information on recipes, diet, how to try to do the diet, do the exercise, that sort of thing. So exercise is another really important way to control blood sugar, isn't it? They need to have proper footwear. Shouldn't exercise if their glucose is poorly controlled or it's really hot or cold, and they really need to be well hydrated. We say that type 1 diabetics should perform vigorous exercise only if their glucose is 80 to 250 and they have no urine ketones. And then exercise, they need to do it gradually, not from nothing to high impact. Because high impact, anybody, even marathon runners that are not diabetic and trained, come back with some hematuria and stuff after they run 26 miles because they've been beating their kidneys. So if somebody has diabetes, they're at risk of vitreous hemorrhage or retinal detachment if they have retinopathy. It can increase their proteinuria because of the trauma to the kidneys. And of course, there's foot and joint injuries if they have peripheral neuropathies. So people can still walk, people can still swim, people can still exercise, but not the same way maybe that a marathon runner would. All right. The last couple slides are nursing diagnoses. These are nursing diagnoses that you should be able to identify from the database from your diabetic patients. And the statistics are pretty amazing. They're saying somewhere around 50% of patients in hospitals, on med-surg units, not OB, but in hospitals are diabetic, and they're there either because of the diabetes or the complications of the diabetes, or they're there for pneumonia and they also have diabetes. Or they're there for an MI or a stroke and they have diabetes. So somewhere almost 50% of hospital inpatients have diabetes. So if you're going to work in med-surg or anywhere, you're going to work with a lot of patients with diabetes. And so you have to really understand the pathophys, the nursing process, and how to apply that. So the risk for injury is huge, patient safety. The issues with surgical recovery may be altered. You really got to manage their blood sugars, don't you? They may have sensory alterations, the neuropathies, which again puts them at risk for what? Injury, burns, etc. They can have chronic pain, neuropathic pain. You've seen them selling some of the new drugs like Lyrica, which is supposed to help with diabetic neuropathic pain. What are some other drugs we give for neuropathic pain? Gabapentin, right, which is Neurontin. Gabapentin is actually an anticonvulsant, but it's usually used, Neurontin, which is gabapentin, used for neuropathies, which is painful. They can use some of these other newer drugs, Cymbalta, which is an SSRI, it's an antidepressant, but the selective serotonin reuptake inhibitors, Prozac, Zoloft, Paxil, Celexa, et cetera, there's like 15 of them now. The SSRIs can manage chronic pain by increasing your pain level. You don't appreciate or feel the pain as much. Okay, so we have retinopathy, risk for blindness, and all the safety issues around that. Good old tissue perfusion, your vascular system, that's the plumbing of your body to get oxygen around. So it can affect the oxygen transport to your renal system, your kidneys. Imbalanced nutrition, often less than body requirements, since we're often talking 90% about type 2 diabetics. Imbalance of food intake and physical activity. Yeah, we always tell you guys exercise. When do you fit that into your schedules, huh?
It's not
Maybe
there.
you'll lose weight after you graduate. I don't know. But
That's the only time.
you know, it's hard. If somebody has hyperglycemia, they do get dehydrated. Y'all understand that. The polyuria, they get deficient fluid volume. That's a really potentially high priority, dangerous complication. Dehydration is a bad thing. The fluid shifts. They get hyperglycemic diuresis, polyuria. What if they have vomiting and diarrhea? All these things can lead to dangerous dehydration. So when we see these hyperglycemic emergencies, one of the first things we're trying to deal with is the dehydration. And then there's good old knowledge deficit. So it's a complex multi-system disease, isn't it? Urinary elimination. They may have trouble emptying. They may have nephropathies, which is the chronic kidney disease. They may have problems with gastroparesis, diarrhea, constipation, and then, of course, skin integrity. We know that if their blood sugars are high, they're at higher risk of wounds, of poor wound healing, of wound infections, and that all has to be then taken into consideration. Sexual dysfunction, impotence, impaired lubrication, painful intercourse, and the self-concept problems around that. Self-esteem issues, especially if they're having trouble with the self-care demands of their regimen, which it's difficult. Anxiety about their diagnosis. Some people, when they get that diagnosis, they already imagine themselves blind with no feet and on dialysis. Because they've seen people blind with no feet on dialysis, and they think that'll happen to them. But it's all about what? Managing the blood sugar. It's all about maintaining their A1Cs below 7. Or even below 6 if they can. Is it easy? No. Is it cheap? Probably not. Fear, coping, powerlessness, social isolation. Ineffective health maintenance. Non-compliance. Now, non-compliance is kind of a funny concept. Because some people are non-compliant because they can't afford the meds or they can't, get to the food. But there's other reasons. Like maybe they're 16 years old and they want to be like their peers. So there's also all of those growth and development things overlaid on, say, a child with diabetes, whether it's type 1 or type 2, they're still a child, right? All right. Now, sick day care. In your study guide, there's a little handout that I put in there from Doctor's Hospital. It's actually back with the competency, I believe. 93, yep. So the other pictures are pretty self-explanatory. The triangle of management, medication, diet, and exercise. It says claims on demand. It's the patient ed material they can gin out of the computer at doctors. And it says sick day plan. Don'ts, do's, call your health provider if. So if you're sick, your blood sugar may rise. Inflammation, increased cortisol, increased blood sugar. Guidelines. The first thing I have an arrow to says what?
Don't stop
Don't
taking
stop
it.
taking
Don't
your
stop
meds.
taking the meds. So if they're on insulin, they should take their insulin. If they're on pills, they should take their pills, because generally the illness will make their blood sugars go up. Don't take other meds, such as cold or flu remedies, because some of these over-the-counter meds can also mess up their blood sugars. Do stick to your meal plan. If you can't eat, try fruit juice, gelatin, frozen juice bars. Drink 1 glass of liquid every hour. If you're also eating, make them sugar-free. Check your blood sugar as often as directed. Survival skills. Call your healthcare provider if you vomited and have diarrhea for more than 6 hours, your blood glucose levels are higher than 240, you take oral meds and your blood sugar is 240 before a meal and stays up, you have moderate to large amounts of ketones in your urine, starting to get into ketosis, or you aren't better for 2 days. But I think the little arrow there is the main concept. Patients should still take their medications, and then they should be in touch with their doctor if they have some of these other things. And that's kind of what this survival skill says. Teach them survival skills with the meds, diet, exercise, complications like hyper and hypoglycemia, how to monitor and interpret their blood sugar levels, and then other resources available to them. There's American Diabetes Association, has a lot of support groups. That's that one there at the bottom. I'm sorry, not com. .org. It's an org. It's an organization. Diabetes.org. But there's also organizations for diabetes educators, most of whom are RNs. Wonderful advanced practice jobs for nursing. And of course, there's NIH doing clinical trials and studies. So they're coming a long way. They've got a lot of, not just some new meds coming down the pipeline, but, you know, just better understanding of how to really control this disease so that people live long, healthy, complication-free lives. Okay? All right, let's take a quick break. Like 15 minutes. And at 10:15, we're going to start and do all the competency 8. Look over these case studies when you're studying. We're not really going to have time to do them because I want to have time for competency 8. But everything is in your study guide. Please study when you're studying for the next test. All right, 15 minutes. I think I need some hydration. Probably a thing of water. Coffee's not. I like coffee, but I can drink water. I really need that more water and less coffee. Drink your water. If you get dehydrated, you'll feel tired.
I need to check.
Keep drinking.
You said what was that?
Oh, she went to her son's meeting.
Yeah, when I was reading Comp 8, my eyes were like rolling in the back of my head. I got so
I know.
confused.
Well, we'll start at the top and work down. Pituitary, thyroid, adrenal.
What we're going to do is going to make a chart,
Yeah, make a chart.
and it'll be like,
Make a chart.
and then put all the
Pituitary,
hormones.
hypo, hyper. Thyroid, hypo, hyper.
Yeah.
Adrenal, hypo, hyper.
That's what I think I'm going to have to do.
Hypo, hyper. Yep, that's the key.
Yeah, it's easier that way.
Yeah.
And you can have a different chart for pituitary, and then a different chart for thyroid, and a different chart for
Yeah, for all the hormones that
So
are
you
in
keep
the
them separate in your head.
pituitary.
When I do it that way, but I can picture it. Sometimes
Right.
like I can close
Well,
my eyes.
I know I'm kind of a, what's the word? I can see where things are on a page.
Like visual.
Very visual, very visual. So if I draw the chart,
I see.
and you can't just look at somebody else's chart, you have to draw it yourself.
My,
Yeah.
Because then it comes out of your brain and out of your pen.
Even if I'm reading,
And
I
then
have
you
to-
study from it, that'll help you.
I make charts for like when we cover competencies that have multiple diseases, and that just helps me. And someone says to me the other day, they go, "You should sell that to other students." And I go, "No,
That's the point is
fine.
no, but not only that, it won't help them.
No,
Yeah,
Because
because
they have to make the chart for it
Themselves,
to
for
process
each of
through their brain. They can look at it all day,
Yeah.
but it's not going to really help them that much.
No.
They didn't create it.
Mhm.
It's by doing it that you learn.
yeah,
My PowerPoints, when I have them in class, I don't feel them. When I read and study, that's the
Then
time I
you do
feel
it.
it.
Well,
When feel
I know
it,
like
get it
Dr.
that
Dixon
way.
and a lot of these folks, for people to be successful in like 1020 and 1060, she says come with your outlines filled out,
Oh.
ready to review.
hmm
That helps a lot of people too.
that's
Or
what
and then you could go back then later and fill it out.
that's what I tell all the students that have been coming in.
Right.
I'm like, you don't understand that my grades have jumped so high when I started reading before class. Like, you would be surprised.
Makes a big difference.
I'm like, even if you have 2 classes and you're so worried because you have an OB exam in one
At least
day,
you know what subject you're coming in to listen to
exactly.
and participate in. Yeah. Yeah, you can't walk in and say, what are we doing today? That won't work.
Just
Were you able to talk to Dr. Dixon?
I did. And it's her fault now. She hasn't sent it in. Now, that was as of last week. Because as soon as we talked, I talked to her, and she goes, oh, yeah, I sent her an email. I sent it to Ken Armstrong. He said, I sent everything to Michelle Dixon. So now it's the ball's in her court. And she hadn't gotten to you and a couple other people yet.
Okay.
I asked
I'll try again
Julie
this afternoon.
Pamphile, and she said she hadn't even looked at Kaplan yet, so she hadn't noticed. I
I'm
said,
gonna
well,
try again
she's
this
in your same boat.
afternoon,
She's
Try
so
again.
sweet.
Yeah, she's really good still. So she hadn't tried it yet, but I said she's probably in the same boat as you, because you
Yeah.
guys weren't here last semester.
That's right.
Michelle's just got to take care of it. I'll bug her again.
Okay.
I'll bug her again, I'm
Thank
sorry.
you.
Because people are doing their diabetes, what do they call it now?
The case study,
They call the case study, they call it a mid-fidelity simulation. So people are coming to me and they're saying, I'm on this Kaplan homepage, where do I click? And it used to say case study, and now it says mid-fidelity simulation. It's the same thing. But if you can't get in, get on the homepage. We gotta get,
Open.
I'll talk to her anyway. I know she's busy, but she needs to take care of that. And we've had all kinds of issues with Kaplan, but that's not your problem. We're paying them a lot of money, and we should be getting better customer service. Hasn't been good.
so now we're doing comp.
Competency aid. I'll leave that little picture there. You can sell that to your classmates. It's also in the book.
Yeah, someone came up to me. Did you know how I make charts? That's I should sell that. The other students. Like, I'm not trying to make a profit off of nursing school.
The amount of time that people at work, somebody else don't have answering the objectives. So, and you have to be able to do that to be able to get the knowledge, so you have what you need to study. It's just so time consuming. I couldn't imagine, I don't know how anybody who has children and a job goes through nursing school, because I struggle just with kids and not working. So I don't know how people work and do it.
I don't think it's a lot. Is it? Let me see.
You at St. Agnes with Miss Oliver on the
I had some very interesting stuff.
patients?
Yeah, one of my patients, which was really not that interesting, but she was on isolation for bedbugs. Yeah, she came in with the other one was on isolation for MRSA, but this patient was bilaterally blind. She had just had her other leg amputated above the knee. She had a trach, she had G2.
Nursing home?
I believe so, yes.
The nursing home nurses take care of her every day.
But she just.
And she got sick. And she had just had the surgery for the other leg.
And then the other patient I saw that was someone else's patient, was the 82-year-old man who ripped his Foley out with the wound still inflated. The neurology had to, I was there when they took the new one in. Me and Leslie, Leslie's patient, actually.
So urology put in a new one. Because of so much trauma. Patient. I got confused with it.
I had, like, the first time I met her, doing clinicals, the first semester that I never met her. I know.
Well, you could see, because you were so busy. Well, there's definitely learning in that, because you saw trach, you saw mutation, you saw G-tube, and you saw Foley put into a patient with traumatized cerebral.
We don't see them now.
But she had
Doesn't
her.
want to see
Right.
it.
So some of the patients come from they're very comfortable with Yeah, when you say mutation. Well, how did Marie Oliver? It wasn't even in the ice. Oh, it's
Is that in the
No, I didn't even like it.
Yes, it is.
I didn't think.
Mayonnaise on it.
I bet, yeah.
Because she said she was going back to the bars, if there was some kind of like duty that she could get on.
She thinks she might have to have surgery or something. When she's older,
But she kind of underplayed it.
Walking around seems to be okay.
She said light walking was okay.
She seems to be okay.
She thought she could do it.
I told her we should just get her a wheelchair. I mean, whoever needs you can push you, and that's that.
Legal. I think we have legal issues around it. Yeah. Yeah.
I felt bad.
I'm glad. I mean, she's a trooper to show up for political like that.
Yeah. Our friend, well, I'm glad she didn't call out because I had a very good.
Our friend was at Children's and there was a cerebral palsy patient in a wheelchair, third degree burns under her legs. But how could she crawled out of the wheelchair?
The wheelchair.
The
Is that her
wheelchair.
personal wheelchair?
And like our friend, she didn't want to put her back in the wheelchair because she was getting used to the bandages.
Right. Well, it's like maggots. They have sterile maggots. If the balloon has maggots in it, it's actually debrided. Right? They use sterile maggots.
Yeah, I've seen that.
But it's not a good thing if they come from the street with maggots.
Yeah. Ugh. That's so gross. But I
And
can.
you guys didn't have clinical practice with snow. But now everybody's kind of even.
It was my off day.
Monday, Tuesday, Thursday, Friday, everybody's had one day. Oh, okay. We're going. I was erase this.
Yeah, I was in Pittsburgh.
All right, let's start. So we can do competency 8. And next week is competency 9 and line replacements. All right, competency 8, page 94, 95, 96. We're going to go basically through the little outline that's on page 96. Also, on page 102, you have some case studies for thyroid while you're studying for thyroid. Hopefully, we'll maybe have a chance to do that a little bit. The vocabulary, of course, you're always looking at that, is page 103. In the back, page 244, 245 has a chart, 247 has a little fill-in. And then the case studies are also, again, they're on page 102 and page 248, same case studies. Thyroid disease, from the following case studies, there's 5 of them. Look at signs and symptoms, nursing diagnoses, interventions, and patient teaching. Okay? All right, so let's talk about the rest of the endocrine system. What we're not going to talk about is reproductive endocrinology. We know that the pituitary secretes reproductive hormones. You learned some of that in OB when you talked about things like oxytocin and luteinizing hormone and that kind of thing. But that still leaves the rest of the endocrine system. We've talked about one endocrine disorder of the endocrine pancreas, diabetes mellitus, and diabetes mellitus. When you hear the word diabetes, it means DM, diabetes mellitus. But we're going to talk about some other endocrine disorders of the pituitary, the thyroid, and the adrenal glands. The endocrine glands secrete chemicals called hormones, right? And these hormones work along with the nervous system to regulate a lot of different body systems. The nervous system works more rapidly. The endocrine system works more slowly. The endocrine system, the endocrine glands are very vascular because they produce and secrete these hormones, depending on which gland, into the blood vessels, and then the vascular system circulates them. So they work more slowly in conjunction with the nervous system to control a lot of body functions. Which means, concept about slowly, if you're giving medications for endocrine disorders, say somebody is hypothyroid. If somebody is hypo anything, you can give them that hormone replacement. So what's the hormone we give people for hypothyroidism? Synthroid, which is levothyroxine, right, which is T4. Is it going to work in an hour? No. Is it going to work in a day? No. It's going to take several weeks, 2, 3, 4 weeks, to regulate, in that case, thyroid hormone levels, to have a normal T4 level, T3 and T4, triiodothyronine and levothyroxine, the major thyroid hormones. It's going to take a couple of weeks to work. So that concept works for all of endocrinology. If you're taking estrogen replacement because you're postmenopausal, it's going to take a couple of weeks to see if it's going to benefit you. That's true with it. And the nice thing about hypo, which is what? Under-functioning of a gland, which means under-secretion of that hormone. The nice thing about treatment is you can replace that hormone with some sort of synthetic hormone replacement. Okay, we can give synthetic ADH. We can give synthetic thyroid. We can give synthetic cortisol, glucocorticoids for somebody that has low adrenal cortex. Okay, and there's names for these diseases. But there's something called a feedback control system. And the best analogy I can think of is the thermostat that controls the heat in your house. The thermostat, the little dial. They're not all dials now, everything's digital. But I'm going to do a dial. Okay, so if you set the temperature in your house on the dial to 70 degrees, what happens if the heat in your house drops below 7 degrees? The heat kicks on. Your furnace will secrete heat until the temperature gets above 70 degrees, at which time what will happen? It'll shut off. That's the same analogy. It works really well with thyroid hormones. But it's true for anything. If your blood level drops below normal, all your hormones have a normal range. It can actually be measured in blood tests. If it drops below the normal, that will stimulate that gland to secrete that hormone until it comes up to normal. If it's too high, that gland will be suppressed or shut off so that hopefully that hormone level will come down to normal. Okay, that's the feedback control system. And I said it's a really good analogy for thyroid because what do your T3 and T4 thyroid hormones control? Metabolism. The basal metabolic rate, which is basically how cold or how hot is your furnace running. So if somebody has hypothyroidism and they're not secreting enough thyroid hormones, their metabolism gets really slow and they're cold, slow, and dry. If they are hyperthyroid, what's happening to their thyroid hormones? They're too high, they're oversecreted, and metabolism becomes too fast, and so their symptoms are around too fast in metabolism, and they become hot, fast, and wet. Right? Okay. Okay, so let's talk first about the pituitary gland. The pituitary gland is a couple inches back of the middle of, between the eyes and about an inch back in a cella turcica of the midbrain, or the frontal lobe, actually. And so your pituitary gland has the front and the back. The posterior pituitary is the back part. That's called the neurohypophysis, and it's attached by nerves to the hypothalamus. There are two major hormones secreted by the posterior pituitary. One is oxytocin, uterine contraction, which we're not going to talk about. The other one, which we are going to talk about, is antidiuretic hormone, or ADH. So it's kind of a weird thing to picture. Antidiuretic means it keeps you from diuresing. So if you're not making enough antidiuretic hormone, you're going to over-diurese because you don't have enough antidiuretic hormone. Antidiuretic hormone pulls fluid back so it's not secreted eliminated by the kidneys. It keeps your fluid balance normal. So ADH controls fluid balance, water balance. Nothing to do with blood sugar. Fluid balance, antidiuretic hormone. So if you're under or hypo secreting ADH, we call that disease diabetes insipidus. So what are the symptoms of diabetes insipidus? Polyuria, polydipsia. If somebody is peeing out large volumes of dilute urine, they're going to be thirsty. Okay, so polyuria. They're going to pee out large volumes of dilute urine, and I mean a lot of urine. Very low specific gravity. The urine is almost like water. So what's the specific gravity of water? 1.000. So they're peeing out almost water, and because they don't have enough ADH to hold on to water. So they're peeing out large volumes of dilute urine, which is low specific gravity urine. and they're going to become intravascularly dehydrated. And if somebody's dehydrated, we say they are hemoconcentrated, which means their electrolytes and stuff are floating around in a small volume of blood. So if their electrolytes are hemoconcentrated, they're going to be high. So what's this word mean? Hypernatremia.
Increased
High
sodium.
blood sodium level. So hypernatremia is what you'd see on the electrolytes of somebody who's dehydrated. And in this case, they're dehydrated because they're undersecreting, their pituitary is not functioning well, maybe their intracranial pressure is too high, maybe they have a brain injury, they have high ICP, they're underperfusing their pituitary, so they're undersecreting the hormones like ADH, so these guys can develop diabetes insipidus. Large volumes of dilute urine with intravascular dehydration and hemoconcentration, and that's where we see the hyponatremia. So what do we treat it with? Well, we're going to replace the ADH. And synthetic ADH is called vasopressin, or deoxydesmoarginine vasopressin. Vasopressin is synthetic antidiuretic hormone. Used to be you could only take it by nasal spray. It wasn't available orally, but they have developed an oral form now. So for people with diabetes insipidus, because their pituitary is underfunctioning, or they have a pituitary tumor or something and they've had their pituitary removed, we need to give them DDAVP, vasopressin, to bring their ADH level up to normal so that they have normal fluid balance. Okay? All right, because we don't want them to get dehydrated, do we? There's a test called a water deprivation test, which I actually had a friend go through. He was a Navy officer and he developed the symptoms of DI. And he went to Bethesda and they actually don't let you drink. And then every hour they watch you getting more dehydrated and more hemoconcentrated until they finally stop and say, "Yep, you have it," and then give you back fluid and meds. And they never figured it out. They said it's idiopathic diabetes insipidus. They did an MRI, they looked for pituitary tumor. They basically just think he stressed himself out so bad his pituitary crapped out. But he has DI, and he lives with taking these medications for life, this medication, okay? All right, so the opposite. This is hypo, so there has to be a hyper, right? If they have too much or increased or hypersecretion of antidiuretic hormone or some chemical like ADH, it's the opposite symptoms. So now instead of peeing out large volumes of dilute urine, they're going to have decreased urine output, and what they put out will be more concentrated. So the specific gravity will be higher in the urine. Then they're going to become fluid overloaded, however you want to say that. Water intoxication is just sort of another word for fluid overload. If you're fluid overloaded, what's one of the main symptoms? Edema. And then, because they're fluid overload, they'll become intravascularly hemodiluted, floating around in large volume of water, and their blood sodium level will be low, hyponatremia. It's a little harder to treat hyper. Hypo, you just replace that, that hormone that's low. But in hyper, you have to figure out what's going on, try to fix the cause. You can give diuretics and fluid restriction symptomatically. One of the most common causes of SIADH is certain tumors. Certain tumors like cell carcinoma of the lung. There are some other tumors that actually secrete, they call them paraneoplastic syndromes. The tumors secrete an ADH-type chemical from the tumor. And so they develop SIADH from this tumor chemical. So for whatever reason, if the ADH is too high, they have to fix the cause, while they're managing the fluid overload with diuretics, fluid restriction, etc. And always patient safety. Okay? So that's the posterior pituitary secreting ADH. Under secretion or hypo ADH is diabetes insipidus. Over secretion of ADH or hyper is called syndrome of inappropriate antidiuretic hormone. I had a student who said, "Yeah, I was on the last question of the NCLEX, and I heard your voice, Mrs. Eng, because I got a question on SIADH." And I said, "I can do this." And I sat for a minute, and I knew it, and I answered it, and it shut off, and I passed. I said, "Well, that was coincidence." She said, "Yeah, but I got it right." So anyway, I'm not saying you'll have an SIADH, but the person I just talked to said they had myasthenia gravis and Guillain-Barré. and they heard my voice, and they're pretty sure they figured it all out. It was they either did myasthenia gravis or Guillain-Barré. She had both. Okay, so that is SIADH, the opposite of diabetes insipidus. They're both about fluid balance, because antidiuretic hormone manages fluid. All right. We're not going to do too much with the anterior pituitary, or the adenohypophysis. It secretes a lot of what we call tropic hormones. Tropic, T-R-O-P-I-C, like tropic. What that means is they stimulate other glands to secrete their hormones. That's why we call the pituitary gland the master gland of the endocrine system, because a lot of these anterior pituitary hormones stimulate other glands. There are reproductive hormones that are secreted. Melanocyte stimulating hormone stimulates production of melanocytes, which is skin color, pigment. Growth hormone. There's been a lot about growth hormone. Children who undersecrete growth hormone, human growth hormone, they are actually the only real medical candidates for human growth hormone replacement. Has to be given IV. It's very expensive. Children with very small stature who are tested and found to be undersecreting growth hormone. It's become a big thing now for keeping us all young, because it does seem to have some benefits for more than just getting taller. Our long bones have fused and we're not going to get taller, but there's a lot of people out there selling things to stimulate or human growth hormone replacements, not FDA approved, for other reasons. But medical reason is for a child that's small stature. Oversecretion of growth hormone. There are a number of endocrine abnormalities around hypersecretion: giantism, Marfan syndrome, acromegaly. I'm not going to test you about all that stuff, but those are people who have abnormal secretion of growth hormone. Those are endocrine disorders. A lot of it is genetic. These are the guys that are 7 feet tall. They're really good basketball players, but then they drop dead of cardiac arrest, and we find out they had Marfan syndrome. Made them really tall, but it also gave them a cardiomyopathy that maybe wasn't appreciated or diagnosed. So that's oversecretion would be some form of giantism. Okay, now this one we are going to talk about. Thyroid stimulating hormone, also known as thyrotropin. TSH stimulates what? The thyroid gland. It's a pituitary hormone that stimulates the thyroid gland to secrete thyroid hormones. So if the TSH is low, if this pituitary hormone is hypo or low, it's going to understimulate the thyroid. If this TSH is high, it's going to overstimulate the thyroid. When we do thyroid hormone tests, you'll see it a lot. It's very common. They'll order T3, T4, and TSH. The T3 and T4 are the thyroid hormones, actually secreted from the thyroid. The TSH tells you, is it a primary thyroid problem, meaning the thyroid itself is underfunctioning, or is it a problem with the pituitary gland, which could be under or over functioning? Now, I'm not going to ask you test questions about TSH, but in your reading, some of you have read ahead, it's confusing, isn't it?
Yes.
Because it'll say, if the thyroid is underfunctioning and T3 and T4 are low, the TSH will be high. And that makes sense. Because if the thyroid is undersecreting T3 and T4, what's the pituitary going to try to do? Increase TSH to try to increase stimulation of your underfunctioning thyroid. So if the thyroid itself is the problem, all of these, if you're an endocrinologist, which I don't expect you to be, the docs will look at what they call the hypothalamic pituitary thyroid axis, or the hypothalamic pituitary adrenal axis. And they'll say, is it the thyroid or the adrenal that's the problem? Or is the pituitary the problem? Or is there something before that that's the problem with the endocrine system? Okay, it's all really cool once you understand the way it all fits together. It's all about hypo or hyper. TSH is from the pituitary. There's also ACTH from the pituitary gland. Guess what gland this stimulates? ACTH stimulates the adrenal gland, the adrenal glands. Adrenocorticotropic hormone. Actually, it stimulates the adrenal cortex. 80% of the adrenal gland is the cortex. So what hormones are secreted by the adrenal cortex? Well, the corticosteroids, the glucocorticoids and the mineralocorticoids. So if you have low ACTH from the anterior pituitary, you're going to understimulate the adrenal cortex, and they can get a disease called Addison's disease, which is hypoadrenal cortex. Or, if it's overstimulating the adrenal cortex, you can get something called Cushing's syndrome, an oversecretion of those glucocorticoids. Okay? I think we mentioned ACTH is one of the things they give for people with, say, MS. If their adrenal glands are working okay, it's essentially a steroid because it's going to stimulate the endogenous secretion of corticosteroids. Yes.
I know that with like Cushing's
Mhm.
and Addison's, there's a lot of specific clinical manifestations.
Don't worry about all
We
that.
don't need to know them.
Well, we're going to get to that in a few minutes.
Oh,
But you already know the manifestations of Cushing's syndrome. And you know why you already know the manifestations of Cushing's syndrome? Because you know the side effects of steroid therapy. It's the same thing. If you're giving the patient prednisone, for example, high-dose prednisone over a long period of time, it's going to suppress the endogenous secretion of your adrenal cortex hormones. That's why you have to wean them off. Because if you stop somebody suddenly from high-dose steroids, their adrenal glands aren't working. They're going to bottom out and get adrenal insufficiency, and they can die. So you want to wean the person off the steroid therapy as you let their adrenal cortex wake up, if you will. And so when you stop the steroids, hopefully you've got fairly normal adrenal cortical function again. But the symptoms of Cushing's syndrome, which would be the adrenal cortex itself over-secreting those hormones, is the same signs and symptoms you would see in somebody on steroid therapy. Okay? Anyway, we'll say that again. So, let's talk about pituitary surgery for a second. Okay, remember I said where it is anatomically. The removal of the pituitary gland is a hypophysectomy. The hypophysis is the Latin name for the pituitary. The transsphenoidal is the surgical approach. So because of where it is, they'll go up through the sphenoid sinuses, punch a hole in the back, and go in and suck out the pituitary gland. That's what I just said. Up through the nose, into the sphenoid sinuses, and then punch a hole and go back between the eyes. But the approach to get to that pituitary is transsphenoidal, meaning up through the nose, back through the back of the sinuses, and then into the brain that way. Because it's close to that part of the brain. So the transsphenoidal is the surgical approach to do the hypophysectomy, which is removal of the pituitary gland. So post-op. When you read about post-op care of somebody after pituitary removal or hypophysectomy, they're going to come back from surgery, they're going to have their nose packed, and you're going to be very careful not to disrupt that little hole that they've sewn shut, right? So they're going to tell them not to vomit, not to cough, not to sneeze, try to prevent those things. They're not going to brush their teeth right away. You want that little hole to close. So what happens if the little hole doesn't close? What can develop? Infection and? Yeah, what else? What could come out through that hole? Well, yeah, cerebrospinal fluid. A CSF leak is what I'm going for. That's why they say, so you have to know why, otherwise it doesn't mean anything. If the patient has clear fluid coming out of their nose, you're going to test it for what? Sugar. Why are you testing it for sugar? Because CSF has sugar, and normal nasal secretions are salt water. Normal nasal secretions don't have any glucose. So why are you testing the secretions for glucose? To see if they have developed a CSF leak from the surgery, which went back through the back of the sphenoid sinuses through the ventricles of the brain. Okay? Ken Armstrong works in ENT-OR a lot at University of Maryland Medical Center. And they had one lady, he said, not that long ago, who came in and for a year she had had clear fluid draining out of her nose. She didn't have the symptoms of a cold. She had clear fluid coming out of her nose. Well, you can follow this line of reasoning here. They did an MRI and found out she had a brain injury, and she had a CSF leak. And that was cerebrospinal fluid. She had a bad headache, too. The CSF had been leaking out through that leak hole into, out of her nose for a year. So they went in, patched the hole, and she was fine. So people who've had head injuries, people who've had extensive sinus surgeries, people who've had transsphenoidal hypophysectomy, are at risk for a CSF leak coming out through their sinuses. Yeah.
We were told that that causes an imbalance.
Of CSF?
Yeah.
Sure.
When it leaks out like that.
Sure.
So what did and she didn't have any symptoms?
She had a headache.
Just a headache.
She had a headache, yeah. Because she didn't have enough CSF circulating. If you have too much CSF buildup, what do we call that? Hydrocephalus. But in her case, it was leaking out. So people with brain injuries, sinus surgeries, hypophysectomies are at risk for a CSF leak. That's why you're checking it. That's why they talk about the halo, as a way of checking for glucose. That's why they say, after hypophysectomy, make sure the patient doesn't blow their nose or sneeze. All of that is to protect that surgical area. Okay? All right, let's talk about the thyroid gland. So I mentioned that the hypothalamus, which is the nervous system, stimulates the pituitary, which secretes TSH, which stimulates the thyroid. There are actually 3 thyroid hormones. T4, which is levothyroxine, T3, which if you've ever taken organic chemistry, is 3 benzene rings with iodine attached, triiodothyronine, and then thyrocalcitonin. Anybody want to take a shot what thyrocalcitonin controls? Calcium, along with parathormone from the parathyroids, which are attached to the back of the thyroid glands. Okay, so the main thing that T3 and T4 do is the metabolic rate, right? Your BMR. They call that the basal metabolic rate. Essentially, how hot is the furnace running? How fast, how much heat are you making? A calorie is a unit of heat. How fast are you burning those calories or not? Okay, so T3 and T4 control metabolism, your BMR. Thyrocalcitonin and parathormone control calcium. So we can test T3 and T4, and we can also test TSH. You don't need to memorize the normals that would be on the lab slip. We do it a lot. There's a lot of, now when people get old, doesn't their endocrine system slow down? Don't we have a lot of little old ladies taking Synthroid and sleeping with 10 blankets on top of them? That's because their thyroid slowed down and they're cold because the metabolism is slow and their furnace is running really cold.
I don't feel bad running for those
10
10 blankets.
blankets and Synthroid. Maybe they need more Synthroid. Okay, and then we can do I-131. Now, one of the chemicals that you need to make thyroid hormone is iodine. So radioactive iodine, I-131, iodine is selectively taken up by the thyroid gland. So in this test, they're going to give a dose of IV I-131, and then they're going to measure how much is taken up over a certain period of time. If they undertake up the radioactive iodine, they're hypothyroid. If they over take up the I-131, it's hyperthyroid. Hold that thought because we can also give a high dose of radioactive iodine to kill off the thyroid as a treatment for hyperthyroidism. And then there's a thyroid scan, the nuclear medicine scan. They give them the radionuclide and they lie under the scanning machine. And they can see the size, they can see nodules, bumps, tumors. People can get adenocarcinoma of the thyroid cancer. Okay, but we do a lot of T3, T4, and TSH. It's a pretty common lab test.
Before this one.
Yeah.
I didn't see it in our PowerPoint. The slide.
Oh, okay.
This.
I don't know why you didn't see it.
It's there.
It's not in the study guide. I
Okay.
don't have the PowerPoint.
Well, anyway, these are your 3 thyroid hormones. T3 and T4 control metabolism, and thyrocalcitonin is for calcium. All right, do you have this one? All right, so now we're going to talk about hypothyroidism.
Is the other ones in our book? 'Cause I want to copy those.
I think it's in your, is it in your,
No, it's not.
in the book?
No, it's not in our PowerPoint.
Okay.
I have it in the PowerPoint.
It's in the PowerPoint.
The PowerPoint on page 98 has, oh, actually it has more. They've added more.
Okay.
They've added more. There's actually more information. I have smaller bullets.
Okay.
There's some additional information added in to the PowerPoint you have here in your study guide. You have a little bit more. There's not less. There's actually more in your study guide. But I want you to understand the concepts instead of a whole bunch of extra words, okay? So, hypothyroidism is undersecretion of thyroid hormones. Metabolism is slow or low. Hyper is the opposite. So let's take a few minutes here, and you're going to wake up And you're going to tell me what you're going to do for the nursing process for a patient who is hypothyroid or hyperthyroid or euthyroid. So over here we're going to have hypo. Think about it. I want the signs and symptoms. I want the nursing diagnosis. Goes with it. I want the nursing interventions. And then we're going to talk about the severe or life-threatening form of hypothyroidism.
When you say hypothyroid
Hypothyroidism.
controls the temperature and the way your body.
Your metabolism, yes.
metabolism.
Yes. I'm probably going to switch to black because that's not showing up as pretty as I wanted it. Okay, over here, we're going to have hyperthyroidism. So they have an increased BMR, right? Okay, so we're going to have the signs and symptoms that go with that. The nursing diagnosis, you're going to tell me. The interventions. And what happens if it's very severe. Life-threatening hyper. Okay? And then in the middle, there's a term that's called U or euthyroid. So hypo is too low, hyper is too high, and what we're trying to achieve, or hopefully what we have, if we have a normally functioning thyroid, is euthyroid. That's what we're trying to get to with treatment. All right, so I think I'm going to switch to black, because I just don't like blue. I couldn't find a blue, and now it's not quite very. So we have a low, okay. It's hypo. Okay, low BMR. So what would be some signs and symptoms of somebody who has hypothyroidism? Now, by the way, the word myxedema that you see on that slide, that's actually thick skin. Myxedema is the accumulation of mucopolysaccharides in the subcutaneous tissue. So it's actually like thick skin. When you study juvenile hypothyroidism, a baby born to a mother who's hypothyroid, it's a term called cretinism, which is not a nice term. You're not supposed to call people cretins anymore. But cretin came from the island of Crete, and a cretin is a hypothyroid infant or child. So they're slow. They have thick skin, wide-spaced eyes, low forehead, all of that.
They almost look like Down syndrome.
Almost look like Down syndrome. So what do we want to make sure we do in pregnant women? We want to check their thyroid function. We want to make sure that they have screening for thyroid while they're pregnant so they don't have a hypothyroid infant or cretin. So if we're screening the pregnant woman for hypothyroidism prenatally, what level of prevention is that? Secondary. I said the word screening.
Oh.
That's your magic word, screening. Okay. For the pregnant woman, it's secondary prevention. Okay, so someone who's hypothyroid, one of the things they're going to have is myxedema or thickened skin. If it's severe, so myxedema is often another word that's used to mean hypothyroid. If it's severe hypothyroidism, they call it myxedema coma. So now that denotes decreased level of consciousness, right? Okay. But in anybody that's hypothyroid, they could have some depression, apathy, forgetfulness, right?
Usually overweight.
Okay, increased weight. Why?
Decreased BMR.
Because they're not burning the calories. They might be eating normally, but they're not burning the calories.
They get a goiter.
Weight gain. Now, goiter is an interesting word. Goiter means enlarged thyroid gland. That, in the past, in some parts of the world, even some parts of this country, people had what we call iodine deficiency goiters. Because if you don't get enough iodine in your diet, it can affect thyroid hormone production, and you can get hypothyroid and develop a goiter, which is hypertrophy or an enlarged thyroid to try to make more thyroid tissue. Now we don't have as much iodine deficiency goiter because why? Because we have iodine in the salt, iodized salt. Okay, so but a goiter could also possibly be hyper if it's tumors or masses that have developed. Sometimes the hypertrophy could even be hyper. So all I want you to know about goiter is it means an enlarged thyroid. All right, so increased weight or weight gain. Okay, so everything is slowing down. Depression, apathy, memory loss. If somebody's depressed, one easy thing to check is their thyroid hormone levels. That's not a common cause of depression, but it's an easy thing to fix if that is the cause, right? Forgetfulness. So everything is slowed down. Weight gain. So their GI tract is slow, and they're going to be at risk for constipation. What about their skin? Dry. Okay, they're always cold. We call that cold intolerance, right? Okay, dry skin. The only thing that's increased in these people is their cholesterol. So they're at risk of coronary artery disease, right? Because of the high cholesterol. Everything else is low. So when we say hypothyroidism is cold, slow, and dry, that fits with the pathophysiology, doesn't it? They're always cold, they think slowly, their bowels move slowly, their skin is dry, they have menstrual irregularities. Your endocrine system is very connected. So you're not supposed to get pregnant and have a baby if your endocrine system is off. So if you're hypothyroidism, your menstruation may stop. If you're really hyperthyroid, the same thing might happen. So menstrual irregularities are for both. All right, so some nursing diagnoses. What are these people at risk for? I'm going to say altered mental status. So they're at risk for injury, right? Okay. So we want them in a safe environment. What kind of room are we going to put them in? Do we want these people to be isolated at the end of the hall, quiet and cool? No, we want a warm, stimulating environment, right? So in NCLEX questions, they're going to say, what kind of room would this patient be in? What situation would be best? And these patients, we want them to be warm and stimulated because they're cold and depressed. They're at risk for injury. What kind of diet?
Low cholesterol.
Low calorie, low cholesterol, right? For the constipation, we want to increase fiber and fluids, right? Basic nursing care, fundamentals. For the dry skin, you might want lotion. Okay. Now for severe hypothyroidism, everything is slowed down. They can develop coma, myxedema coma. I wanted the word coma, sorry. Now they're unconscious, or so lethargic that they are becoming unconscious. They get slow, and then they can actually become unconscious. What happens to the vital signs? What do you think the pulse does? Decreased pulse. Bradycardia. What do you think the blood pressure does? Hypotension. What do you think the respiratory rate does? Drop. Okay, so, and their body temperature, very good. So they can get hypotension, bradycardia, they can get hypothermic. Hypothermic, their body temperature drops. So now you have a life-threatening situation. Say the patient's elderly, they've had their thyroid removed, they ran out of their synthroid, it's cold outside. All of those things would be things that could cause myxedema coma. Paramedics come, take her to the ER, have to do ABCs, make sure that we bring up her blood pressure, her pulse. So what do we treat hypothyroidism with? Well, basically, it's you give them hormones. You give them thyroid hormone replacement. The brand of T4 is Synthroid, but you've also seen it probably as levothyroxine, which is the generic name. You give them Synthroid. Now, you can give it IV in an emergency situation. You can give IV T4 to bring up their blood levels so that they become, the goal is to make them euthyroid, right? Okay. So you need to think nursing process. Because you know the pathophys of slow, cold, and dry and the decreased metabolism, you want to make sure you're monitoring the signs and symptoms, intervening appropriately, putting them in, diagnosing, putting them into, whoops, sorry, that belongs over here. Sorry, wrong column. We do have nursing diagnoses that say alteration in nutrition greater than body requirements, right? That's what weight gain is. We also have a nursing diagnosis that says alteration in skin integrity, dry. We also have one that says constipation. Nurses can actually diagnose constipation. We used to say alteration in bowel elimination, less than something, something. Now you can just call it constipation. That's a nursing diagnosis, isn't it? Okay. So you have your signs and symptoms, you have your nursing diagnoses, you have your interventions, and this would be the severe or life-threatening emergency, ABC, myxedema coma. But myxedema is the thick skin, thick, dry skin. Okay? All right. Hyperthyroidism. So why is this blue? And why is this red?
Cold and hot.
Cold and hot. Slow, cold, and dry. I know I had to use black because blue is running out, but I'm going to use red over here. So if this patient's metabolism is slow and they're cold, slow, and dry, what do we have over here? The opposite of cold is hot. The opposite of slow is fast. And the opposite of dry is wet. Okay. So hyperthyroidism, signs and symptoms. What's the opposite? These patients are going to be anxious, shaky. They have insomnia, nervous. Over here, the really severe form of that can actually be delirium, which is still risk for injury, just like too slow. Over here, we're going to have too much sleeping, right? Weight gain, sleepy. Okay, so these patients sleep too much. These patients have insomnia. Everything is sped up. So they're always hot. What else?
Weight loss.
Weight loss, right? Could have weight loss. Could become weak with either one. What else? What's the opposite of constipation? Diarrhea. Okay. What's their skin look like?
Sweaty.
Flushed, sweaty, diaphoretic, flushed, diaphoretic. Good. All right. So what's the nursing diagnosis for this one? Anxiety is actually a nursing diagnosis. But they're also at risk for injury, aren't they? You said they can be very impulsive, nervous. So I'm still going to say risk for injury. Because if somebody becomes delirious, they're definitely at risk for injury.
Deficient fluid volume with the diarrhea.
That's right. So what kind of environment? Well, okay, diarrhea. You want to now have increased calorie diet. You still want increased fiber. Fiber is good for both. And it's really important that they have fluids because they have diarrhea and they're sweaty. Again, you might want to keep the skin dry. Oops, that's over here. This is alteration in nutrition, less than body requirements, right? Sorry about that. Keep wanting to put that. Alteration in nutrition is the nursing diagnosis. The food and fluids is here. Right? Okay, so what kind of room do you want the patient in?
Quiet.
Quiet,
Low stimulating.
quiet, calm environment.
Cool, quiet, calm. You see this first word I wrote? Over here I said you want them to be in a warm, stimulating environment. 10 blankets, right? 10 blankets. Over here, what room do you want a hyperthyroid patient in? Cool and quiet. Okay, this is the patient where you want in the private room at the end of the hall. Cool, quiet. You don't want to increase their stimulation. They're already too hot and too fast. So at risk for injury, alteration in nutrition, diarrhea. You want to do the interventions around that. The most common cause of hyperthyroidism is an autoimmune disease called Graves' disease. It's an autoimmune disease, which means it's higher incidence in which gender? Women. Young women can get Graves' disease. Actually, in the White House, George I and Barbara Bush both had Graves' disease. He was diagnosed when he developed atrial fibrillation. He had tachycardia. And she actually has the exophthalmos. So here's one of the things you see in hyperthyroidism. There's Hashimoto's thyroiditis, Graves' disease. There's a couple of causes of hyperthyroidism. But exophthalmos is what? It's about the eyes.
Oh, the eyes are huge.
Bugging out eyes. It's behind the eyes, pushes forward. Exophthalmos. Now with treatment, sometimes it goes down a little bit, but it may be permanent. Exophthalmos is one of the symptoms of hyperthyroidism, along with the other things we identified. Okay, but you always think in terms of nursing process. So the severe form of hyperthyroidism is called what? Anybody know? Thyrotoxic crisis, or another name is thyroid storm. Right. So if this is myxedema coma for hypo, this is thyroid storm for hyper. Okay? Thyroid storm. And so now we've got changes in vital signs, right? So turn this around. What would happen to the pulse? Severe tachycardia or tachydysrhythmia. It's like atrial fibrillation. What happens to the blood pressure? Severe hypertension. What happens to the respiratory rate? Rapid. What happens to the body temperature? High. Hyperthermia. They can get febrile. It's a rare cause of high fever. Hyperthyroidism, thyroid storm. They can become hyperthermic. And delirious, which is altered mental status. Okay, so the treatment for hyperthyroid gets a little more complicated. With hypo, we can just replace that hormone that's low, right? Which is to give the synthetic, what I said here is thyroid hormone replacement, like Synthroid. It's usually given PO, it's usually given Q-Day. All right, so it increases the metabolism, right? So what is the side effect of Synthroid if you give too much? They get hyper. What time of the day do you want to give Synthroid? In the morning. Why do you want to give it early in the morning? Because it's a stimulant. Why don't you want to give it at night when they're going to sleep? Because it can cause insomnia, which is too much hypo treatment for any endocrine disorder makes them hyper. So the side effects of too much Synthroid would be this kind of stuff. Tachycardia, insomnia, all the things you would see if you give them too much, you make them hyper, right? Okay. So POQ day in the AM. All right, so now for hyper, you can give antithyroid meds. They used to have old iodine meds. If you've ever heard of Lugol solution or propylthiouracil, those are medications that we give to decrease hormone replacement. They're iodides. They bind and prevent the production of hormones, thyroid hormones in the thyroid gland. They're called iodides or antithyroid drugs. Antithyroid drugs. The main one we have now is Tapazole. 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 Now, if that doesn't work, if the antithyroid meds don't work, we can do I-131 ablation. Anybody know what ablation does? It kills off that tissue. If we're ablating the heart or ablating something, we're ablating the thyroid with radioactive iodine because iodine goes to the thyroid and it kills off thyroid tissue. So this says I-131 radioactive iodine ablation. And the third thing is surgery. Right? You can take out part or all of the thyroid gland. You may make them hypo, but that's easier to manage. So if the meds don't work, the antithyroid meds, and the I-131 ablation doesn't work, they can do a subtotal or even total thyroidectomy.
Aren't these hypothyroid, like, those are eyes not closed either, and you have to, like, take them shut
Yes,
and
well,
sleep?
possibly. So if you have a patient with exophthalmos, what are they at risk for? They're at risk of eye injury. They may need to have eye drops. They may need to even have their eyes taped at night. So they don't do what? So they don't scratch their corneas. Right. Very good. Okay, so subtotal or total thyroidectomy would be another treatment for hyperthyroidism. Now, if somebody has adenocarcinoma of the thyroid, which is potentially metastatic and fatal disease, they're going to take it all out too. If somebody has cancer.
The middle part?
radioactive iodine.
Oh,
That
that's
was
what
a
it is.
use for.
Oh, euthyroid's normal. That's
Oh,
what you
I'm
want.
sorry.
You don't have to treat normal. Normal's already okay.
I'm just copying.
No, that's fine. But yeah, I want you to know what it means. If it's not broke, don't fix it, right? You ever heard that saying? It's not broke, don't mess with normal. All right, so that's what we just did. The symptoms of hypothyroidism or myxedema. If you see the word myxedema, that's just hypothyroid. If you see myxedema coma, it's a life-threatening hypothyroidism. So we went through, well, the diagnostic test, they would expect to see the T3 and T4 below. The nursing diagnoses, interventions, and treatment we talked about. Sorry, guys. All right. You don't even have a PEDS test. For hyper, you see my guy is big in hypo? See my little guy, shaky guy in hyper? Because he's skinny and shaky. Because he has Graves' disease or hyperthyroidism, and so he's hot, wet, and fast. So that drives the signs and symptoms. Severe hyperthyroidism is thyroid storm. So now you've actually got effects on vital signs. I mean, they could be a little tachycardic even with, regular hyperthyroidism. But when they get really severe or thyroid storm, it can become life-threatening. By the way, they're going to be in a safe environment for their altered mental status. We can give them a medication that slows down their pulse and their blood pressure. Anybody want to take a shot at what category of meds that would be? Beta blockers. Propranolol, metoprolol, atenolol. The alols are beta blockers. It'll help the blood pressure, lower the blood pressure, and also lower the pulse rate. And it actually stops the shaking. Did you know you can take propranolol for stage fright? It'll block down the nervousness. So it helps the nervousness, it helps the shakiness, it helps the hypertension, and it helps the tachycardia. Beta blockers. You also want to be concerned about this body temp, don't you? Patient's very febrile. Now you can use cooling blankets, but what medication do you want to give for somebody that's febrile from hyperthyroidism? This is a trick question. Antipyretics, which one? Nope. Tylenol. What's the generic name? Acetaminophen. Acetaminophen is the medication to lower the body temperature. And that's because aspirin and NSAIDs increase thyroid hormone levels. Aspirin and NSAIDs, which are really the same thing, will actually increase thyroid hormone levels, make it worse. So it's contraindicated to use aspirin and NSAIDs for the high fever in thyroid storm. You always want to give acetaminophen. Acetaminophen for the temperature, for the fever, beta blockers for the hypertension and the tachycardia in a safe environment. And then you could go into the anti-thyroid drugs, I-131 ablation, or take part of it or all of it out, the surgery. Okay. Post-op, yes.
Sorry.
Questions? Good time for questions. Go ahead.
I don't understand why do we give them high fiber?
If somebody has diarrhea, guess what the fiber does? Makes the stool formed. Metamucil is a fiber. They use it for constipation. You have to drink plenty of water. They also use it for diarrhea. Either way, the fiber works, right? Did you learn that about diarrhea? Fiber is good for constipation and diarrhea. Because in diarrhea, it takes the liquid stool and forms it into a normal poop. Right. So you want fluids for both, and you want fiber for both. Yes, it's a treatment for both. Good question. And then you mentioned, Jessica, the exophthalmos and preventing corneal abrasions by, giving them eye drops, maybe even taping their eyes closed. All right, very good, very good. Good questions. All right, so if the patient is hyperthyroid or they have thyroid surgery and they go in to get a subtotal or total thyroidectomy, first of all, where is your thyroid gland located? Right here. Lots going on in your neck. The thyroid gland is there, and it has a lot of blood supply. Remember, they're very vascular. So one of the complications of the surgery would be hemorrhage. The other thing they have a lot of, behind the thyroid is the vocal cords and the nerves that innervate the vocal cords, which you need to speak. And if you have irritation of those nerves, you can get hoarseness. The other thing is really important is your airway. your airway's also there. So the number one risk after a thyroid surgery would be an airway obstruction. That's why we say to have a trach set and suction at the bedside of a patient post-thyroidectomy. Because what happens, where's your thyroid? Up here. So if you have too much swelling or bleeding and it obstructs your airway, they got to get a trach in you and they got to do it fast. So the trach set and the suction is there in case they need to. In case there's a post-op airway obstruction from a complication. Because your airway is there, a lot of blood vessels are there, your nerves to your vocal cords are there, and remember your parathyroid glands are on there too. So when you remove the thyroid, you also remove the parathyroids, and the patient then becomes at risk for hypocalcemic tetany. What's tetany? That's the muscle twitching from very low blood calcium levels. All right, so all of these are possible complications. Those are your three main things. You're watching for airway obstruction. They usually have oxygen, maybe even humidified O2. You have the trach set and suction handy, nearby. You're watching for hemorrhage. You're having them state their name, otherwise they're on voice rest, and you're watching their blood calcium levels. You're managing their pain. Maybe this will wake everybody up. Okay. Post-op pain management, maybe a PCA pump with an opioid, IV patient-controlled opioid, and then they go to oral opioids and then to something else. Hydration and nutrition is very important. Remember where the thyroid is. They may need soft foods for a while, nothing too scratchy. What position do you put somebody in right after a thyroid surgery? You want their head up. You want semi-Fowlers, right? Okay. Let me see if this question is in your study guide. If not, I'll bring it next week. It might have been taken. It might have not gotten in. We do have your critical thinking exercises. Look on page 102 real fast. You should now be able to, over the next week, go back and look at this. Page 102, it's also in the back. Miss Johnson is a 36-year-old female admitted to ICU from ER with a diagnosis of thyroid storm. She's on anti-thyroid medication but has not taken them for several weeks since she's had the flu. So now you're going to tell me the signs and symptoms, top 3 nursing diagnoses, nursing interventions, and patient teaching for a patient with thyroid storm. Second case, Miss Roberts is a 58-year-old female with a diagnosis of myxedema, which just means she's hypothyroid, secondary to autoimmune thyroiditis. So she's slow, cold, and dry. Nursing process. The second number 2, don't ask me why they're numbered this way. Anyway, the next patient, Miss Harris, is a 72-year-old female admitted to your unit, SP, which means what? Status post, or post. Status post, complete thyroidectomy following a diagnosis of papillary adenocarcinoma of the thyroid. Discuss post-op management for this patient. So we just talked about post-op management. She's had a thyroidectomy because she has thyroid cancer. Number 3, the next patient, Bobby Jones, is a 3-year-old male recently diagnosed with juvenile hypothyroidism. Kind of late to be diagnosing it, but maybe he's got developmental delays and they finally did thyroid studies and he's hypothyroid. This patient will need thyroid hormone replacement therapy for the rest of his life. And hopefully, when he becomes euthyroid from treatment, he'll be okay. With, whatever he's lost before that, he's lost, but hopefully he can catch up. And the last one says Susan Peck, that was number 5, is a 14-year-old female recently diagnosed with Graves' disease. Remember, girls, younger women are at higher risk of autoimmune disease. Yes?
Going back to the last patient, would that affect his growth pattern?
Yes, it could. Because the endocrine system is all connected. So if you're hypothyroid, you might be hypo other things as well. It could affect the pituitary and other things. They're all kind of linked together. It's possible. You'd have to have an endocrinologist work on. And then the female with Graves' disease is hyperthyroid. And so she's going to probably take anti-thyroid meds. And she's going to you're going to have to manage and intervene while these meds work. Remember, they take a while. They take several weeks. The Synthroid will take a couple weeks. The Tapazole will take a couple weeks to see how well they're going to help or not help. Because just because we give meds doesn't mean they're working. We also have to evaluate the efficacy of the treatment that we're providing, right?
Is Graves' disease, usually hereditary?
It can be. Autoimmune diseases do have some family history. Some. Not everybody. You know, some people will get lupus, which is autoimmune, and nobody in the family has it. Somebody will get Graves' disease. Somebody will get Crohn's disease. There tends to be a familial history.
Excuse me.
Yes.
Well, once somebody gets the disease, like lupus, is it possible that their kids would have it?
Well, that's my point. Yes and no. There tends to be, in some cases, depending on the type of lupus, there may be some family history or genetic tendencies.
There's nobody had it before.
No, my daughter has some kind of variant of lupus, and nobody in the family's ever had lupus. So, you know, who knows what caused her autoimmune process to kick in. It's not hereditary in that case.
Okay, well, since hers was not hereditary, is it possible that her kids would be hereditary?
It's less likely. Never say never in medicine. It's less likely, yeah. Good questions. All right, last but not least, the adrenal glands. You need to stand up and stretch. You work nights. You study. No Pete's test today. Usually that's when I lose everybody. Okay, this is the last, we're on the very last stretch here, okay? And then you can go back and look at everything. There is some kind of a question about thyroid, but I don't see it in your study guide. I just see the case studies I just mentioned. Page 247 is kind of interesting. You want to do that right now? Page 247 in your study guide. So you're going to wake up and you're going to tell me whether each of the following signs or symptoms, while it's fresh in your mind, is more closely associated with hypo or hyperthyroidism. You can still study it later. 247. Instead of doing the test questions, which we can put on Blackboard, let me give you this little exercise. All right. Page 247. Lethargy or apathy, hypo or hyper?
Hypo.
Hypo. Hypo. All right. Next one. Exophthalmos.
Hyper.
Hyper. Mood swings. Moody, nervous, anxious. I think that's more hyper. Yeah. Hand tremor at rest. Hyper. Weight loss.
Hyper.
Hypo. Hypo. Oh, I'm sorry. No, you're right. You're right. I'm wrong. Hyper. Hyper. I don't know why I thought it said gain. It doesn't. Weight loss. Hyper. Good. All right. Hyper. Warm, smooth skin.
Hyper.
Warm makes it hyper. Profuse diaphoresis.
Hyper.
Hyper. All right. Generalized non-pitting edema.
Hyper.
Hypo. Oh, they're all the same. Oh, whatever. Dry hair and skin. Hypo. Intolerance to cold.
Hyper.
Hypo. Okay. Loose bowel movements.
Hyper.
Hyper. Good appetite. Well, that could be either one. Usually it's hyper because they're losing weight. They have they have more appetite. Everything's slowed down in hypo.
Hyper.
So it's more likely to be hyper. Tachycardia.
Hyper.
Hyper. Incoordination. Actually, I think they're going for hypo because the hypo tend to be kind of slow and clumsy. Yeah, slow and clumsy. So that word is a little, yeah, that's a tough word. It could mean, kind of could mean either one, but they're going for hypo. All right. Now, the next one says explain why a goiter may be a sign of hypo or hyperthyroidism. So we kind of talked about that. It's normally hypertrophy for hypo to try to make it a bigger, more functioning thyroid, but it could also be hyper if they have masses or tumors. And the next one
It's hypo again because of.
hypertrophy. I'm talking about goiter.
Right.
Goiter is an enlarged thyroid. So if somebody's not getting enough iodine in their diet, their thyroid gland tends to enlarge, try to make more thyroid tissues, try to make more thyroid hormone. So we don't see as much iodine deficiency goiter, but iodine deficiency goiter was associated with low iodine in the diet and hypothyroidism. But you also can see enlarged thyroid if they're developing tumors or masses.
Oh.
Lumpy, bumpy, benign or malignant tumors. And then the last one is kind of interesting. Why both hypo and hyperthyroidism can result in diminished cardiac output. So if you're really, really low pulse rate, it decreases your cardiac output. Because your cardiac output is your heart rate times your stroke volume. So if the heart rate's really low, you're going to have decreased cardiac output. Okay, your heart rate is your cardiac output is your heart rate times your stroke volume. So if your pulse is way, way, way too high, you won't have good filling time. So now your stroke volume is decreased. So if your pulse is too low, you don't have enough heart rate to get good cardiac output. If your pulse is way too fast, you don't have enough stroke volume to get good cardiac output. So either way, at either extreme, it affects cardiac output. Alrighty. That's probably all you need to know about thyroid. Now, last but not least, we have adrenal. See, I could do this all day. It's so much fun. All right. And when you get into it, it's pretty cool. All right, the adrenal glands. Again, controlled by the secretion of ACTH, adrenocorticotropic hormone, from the pituitary. You have the hypothalamic pituitary adrenal axis. You're not an endocrinologist, don't worry about it. The adrenal hormones, we have the adrenal cortex, the outer 80%. Where's the adrenal glands? Where are they located? On top of the kidneys. So usually if they do a radical nephrectomy, they're taking out that adrenal gland that's attached to that kidney. So you have adrenal glands on both sides. The outer part, the 80% of the outer part of the adrenal gland is called the cortex. Yes.
If you are removing a kidney, you automatically take the adrenal gland
Usually
with
yes,
it?
because it'll lose its blood supply.
Okay.
Yeah. But you have adrenal gland on the other side, just like you have kidney on the other side. Okay, so the hormones normally secreted by the adrenal cortex are your glucocorticoids. Those are your endogenous corticosteroids, if you will. A little bit of androgen, which women and men have, and mineralocorticoids. So don't worry about androgen and mineralocorticoids. We're going to go with the glucocorticoids. The medulla, the center, the inner core, the center 20% of the adrenal gland, has the medullary hormones. That's where you secrete your catecholamines. Adrenaline is another word for what? Epinephrine. Epinephrine is adrenaline. Epi and norepi do what to your pulse and blood pressure? Increase. Those are your flight or fight stress hormones. Increase the pulse and the blood pressure. All right, so knowing that, if the adrenal cortex is underfunctioning and they're hypoadrenal cortex, we call it adrenal insufficiency. Another term for that disorder is Addison's disease. So the adrenal glands are underfunctioning. It's the opposite of hyperfunction or oversecretion of adrenal cortical hormones, which we call Cushing's syndrome. So let's look at Cushing's syndrome first. If somebody has Cushing's syndrome and they're putting out too much of these glucocorticoids, these corticosteroids, if you will, what do we see when we give somebody steroid therapy? Weight gain, the moon face, the hyperglycemia, steroid-induced hyperglycemia, hypertension, mood swings, osteoporosis. Doesn't that look like the signs and symptoms of the side effects, rather, of steroid therapy? It is. It's the same thing. In this case, the adrenal gland or the adrenal cortex itself is oversecreting these glucocorticoids. And when you oversecrete glucocorticoids, or you take glucocorticoids, prednisone, dexamethasone, Solumedrol, Solucortef, whatever, it can cause these things. Increases your appetite, you gain weight, you retain fluid, you develop that moon face, what they call the centripetal fat distribution, the thick neck, high blood sugars, high blood pressures, mood swings, insomnia, flushing. Anybody ever taken prednisone? It's horrible. Stay up all night, feel real sweaty. And long term, it can also cause osteoporosis. Okay. The opposite then, or under functioning adrenal cortex, adrenal insufficiency, would be now the patient has, instead of high appetite and weight gain, they have anorexia, weight loss, they have nausea and vomiting, their blood sugar now is low, their blood pressure now is low, they can get dehydrated, weak, and actually get a little bit lethargic. Now for hypofunctioning, we can replace those hormones that are low, right? So we give them those hormones that are low, patients with Addison's disease. Apparently President Kennedy had Addison's disease, but we didn't know everybody's medical history like we do now. So anyway, so Addison's disease is hypoadrenal cortex. This is probably the only condition I know of where you want the patient to eat a lot of salt. Calories, salt, fluids, all that's good. Because you want to bring up their blood pressure. So they can have a nice high salt, high calorie, high fluid diet, right? Where the opposite is true. If somebody's on steroids, don't we tell them to eat a lower carbohydrate, lower calorie diet because they're gaining weight? Okay? So that's Addison's disease, which is hypoadrenal cortex, and Cushing's syndrome, which is hyperadrenal cortex. The last one I want to mention here, my last slide, is a benign tumor of the chromaffin cells of the adrenal medulla. And it's called a pheochromocytoma. Cytoma means it's a benign tumor. It's a tumor that forms in the adrenal medulla. It's one of the very rare causes of hypertension. An adrenal tumor can cause untreatable, basically, hypertension. If somebody has bad hypertension and we don't know why and the meds aren't working, they should do an MRI or a CAT scan of the abdomen, see if the patient has an adrenal tumor. If the patient has a pheo, they can surgically remove it and the problem goes away. It's a very rare cause of, hypertension unresponsive to regular treatment. Because what does the adrenal medulla secrete? Epinephrine and norepinephrine. So if you're having episodes where this tumor is secreting epi and norepi, people can have these episodes of severe hypertension, tachycardia, anxiety. Kind of comes in paroxysms or episodes. They'll go to the ER, they feel terrible, and they can't really figure out what it is. I actually had a friend who had basically hypertension unresponsive to treatment, and they finally did an abdominal CT and found an adrenal tumor. She had a pheo. Surgically removed it, she's fine. So if you think about pheochromocytoma, think epinephrine, think hypertension, and managing that blood pressure. They can give antihypertensives until they take them to surgery, but the surgery is the fix. Okay, you ever heard of pheochromocytoma? That's what it is. It's a benign tumor of the adrenal medulla. And if you know what hormones are secreted, you know what you're looking at, you know what signs and symptoms to expect, you know what to monitor. So what are you going to monitor? Blood pressure, pulse. Right, exactly. Good. That's it. So use your nursing process, look at your case studies. Basically the ones here for you are for thyroid, because that's the most common of the endocrine disorders. Those of you who've worked in long-term care, you've seen people with hypothyroidism. As we age, the endocrine system slows down. Graves' disease and hyperthyroid is not that uncommon. I have a student who's getting thyroid removal soon. I think when the semester's over. Okay. I'll put those little practice test questions on Blackboard, since they're not in your study guide this semester. But they're just another way to practice looking at the STEM, looking at the choices, picking the right answer. And the nice thing about these test questions, I don't remember to put it on Blackboard, is that you would be able to figure out the answer even if you hadn't had the lecture. I like to actually do them before the lecture because they're tests, they show you how your test-taking skills can get you to the correct answer on a question, even though they're both about hyperthyroidism, I think. All right, guys. Thank you.
We're doing test review?
Oh, gosh, it's right here. All right. Some of you don't have that much to look at, which is nice. Sorry, you're also, I'm glad you said something. Rosa. Clara. You say Sidoni or Sidoni? Sidoni. Sidoni. William. Priscilla? Yeah. Leslie? Emily? Elizabeth? All right. Thank you. John? Yeah, I'll see you guys tomorrow in your super lab. Christelle?